Please tell me that you can see my slides.
Okay, great. I've got an application, AGHPF.
Can you see my slides? You paused.
Audio.
Audio. Take a video.
I can listen from that. The video is okay. So ukitaka kujua participants, wacha imalize kwanza. Unaikuja hapa unaona. Leo ni I'm speaking on that thing. Unmute.
Good afternoon, everybody. Good morning. Good evening, depending on where you are in the world. Please, if you're following us on Zoom, please just go down to the left part of your hand of the screen and turn off
global healthcare. That's where I was.
Please go down to the left hand part of your screen and turn your microphones.
There's a
we have a number of microphones that
video, you can see them. How about on a connect? Like you and your director.
A few of our participants on Zoom who have their microphones on, would you please mute? Okay. So, again, good afternoon and welcome to our presentation today. SARS-CoV-2 Surveillance and Lockdown. My name is Kilian Songwe. I'm the president at the Global Healthcare Public Foundation. I'm the chief scientific officer here with a lot of years of experience in management systems and consultancies around policy. Actually, Global Healthcare Public Foundation has been around for almost 18 years, working in over 14 countries in the world. And we've taken at least 84 countries, 84 institutions to accreditation or certification to some international standard or another. So what do we want to achieve this afternoon? Basically, I'm going to be looking at a couple of interesting things around the coronavirus pandemic. I'll be looking at the pandemic itself. I'll be looking at the transmissions. I'll be looking at surveillance. I'll be looking at testing and the lockdown, because this is a big issue in terms of trying to get people to come back to work. So those are the things I'll be looking at. So going on to so talking about SARS, severe acute respiratory syndrome, coronavirus 2, that's exactly how it gets the CoV-2. It's a strain of the virus. It actually has its origins from a zoonotic world. So in this case, it's a bat disease, bat coronavirus. And one of its main modes of infection is close contact with somebody who is already infected through respiratory droplets, coughs, sneezes. It's important to note that the transmission of the SARS-CoV-1 and the SARS-CoV-2, the infection rate is for every infected person. It is understood that the infection rate is anywhere between 1.4 to 3.9. So about 4 people will get infected as a result of the first infection. So let's look at a timeline for transmission. Basically, within the first 3 phases of the virus transmission, predominantly we're looking at infection from predominantly animal infection to human infection. That's the very early phases of the virus. And then we move into a phase 4. In phase 4, we're looking at human-to-human transmission. And this is exactly where we were in the latter days of December 2019. And then phase 5 and 6, that's when we get into the pandemic phase. This is just a massive widespread. So we saw the spread from Wuhan in China to Europe and then to the United States and then overlaps in the northeastern Africa and then to the rest of the sub-Saharan Africa. Then you have the post-peak. This is the area where lots of countries are beginning to talk about the leveling of the curve and they're beginning to reduce the number of new cases. This is also a very important phase. But then we terminate with the post-pandemic phase. So traditionally where we actually are today is around phase 5 and 6 for the most part of the world. As much as people might be, some countries are beginning to report lessening a decrease in new cases, we're still having a huge amount of human-to-human transmission, which is important to note. So again, widespread human-to-human infection. So I just want to give you a quick timeline for us to be able to appreciate what is going on. Let's look at a timeline. So in December 2019, when the virus first broke, it was called the new coronavirus. When it first broke, what you look at here is the cases in China, 27 confirmed cases. When you look at the bar at the bottom of the picture here, you see this was the very early stages of the disease. This is December 2019. Then we go down 3 months later into March 31st, 2020. What you now see is suddenly there's a big spread. You have the United States reporting 21,000 people. You have Iran at 3,186. You have Canada at 1,169. And then Turkey at 1,610. But when you look at the map of the world at this point, you begin to see that it's truly a pandemic. Almost every part of the world is touched. And this was March of 2020. Then we move on to just last week, May of 2020. What you see in May of 2020 is basically a severe infection and cases all across the world. So we now look at the average disease death. So we now have a pandemic in our hands, but then when we look at the pandemic that we have and we compare it to average disease deaths per day worldwide, and I want to bring your attention to the fact that this slide was prepared in April of this year, April 24th of 2020. You look at the COVID-19 deaths per day, it runs at 1,647 deaths per day. But when you compare that to HIV and AIDS, which has been around us for a while, you see 2,110. You compare that to tuberculosis, 3,014 deaths per day. So yeah, COVID it's a new distraction. It's going to change our world as we know it, but there are other diseases that have been around and are taking away more people. So let's look at the incubation periods for COVID. COVID has an incubation period well into the 2-week range if you look at what is there. And then there are antibodies that are developed thereafter. But it is very important to note that there is an asymptomatic phase with the virus. And the asymptomatic phase is really important because there are a lot of people going around, and we're going to see in one of the subsequent slides that there is a huge percentage, a small number of people, about 5%, that are asymptomatic yet spreading the virus. So just to take a look at the world's reaction to the pandemic, if you look to the graph on your left, Asia, Australia, New Zealand, versus the African graph on your right. One of the big things that a lot of the governments were very quick at doing was trying to do a lockdown. So you look at the Asia, Australia, New Zealand lockdown, they started somewhere at about January 16, and there was a progression on the lockdown all the way through April. Different countries were doing some kind of a lockdown. And then in Africa, we started the lockdown in March, or just end of February, the last week of February. Nigeria was one of the first countries to do a lockdown. And then you come all the way down to Lesotho that did its lockdown just before April. Again, when we talk about the lockdown, different countries did their lockdowns in different methods. So you had some countries that had a total military lockdown, and you had some other countries that had just citywide lockdown, so you could not move from one city to the next. And then you had other countries that had lockdowns, which were actually just curfews, 6 p.m. to 6 a.m. or 7 p.m. to 6 a.m. But now when we look at the virus case numbers across the continent of Africa, you actually can relate some of the cases, the number of cases in the different countries, with the level of lockdown that the different countries actually have exercised. So moving from the story and the progression of the virus into the pandemic and across the world, let's look at what is going on with surveillance, basically trying to identify people who have tested positive for the virus. The World Health Organization actually ID'd 4 basic objectives around surveillance. The first and very important one, of course, all of them are important. However, the first one says, we want to monitor trends of the disease where human-to-human transmission is occurring. That is very important, so that we can actually start the process of quarantine and isolation. Then there is rapidly detect new cases in countries. This is very important. A lot of the new cases were actually migration cases. These were people who were either coming from, flying from one country into another country, and then as a result, because it's a human-to-human transmission, they infected people in those countries. Provide epidemiological information to conduct risk assessments at national, regional, and global levels. This is as well very important to know what was going on, or what is actually currently going on in the different countries. And finally, one of the big objectives in the surveillance for the World Health Organization was to provide epidemiological information to guide preparedness and response measures. And the response measures are very different from one country to the next country. So, contact tracing in surveillance. Contact tracing basically, as I mentioned, is one of the old tools in public health. Okay. Basically, with contact tracing, we're finding out contacts who have been tested positive to COVID-19. And as I said earlier on, contact tracing is an old tool to control the spread of infectious diseases. And it's currently one of the big pillars today in trying to manage the infection rates in countries. But it's very important to note the rates of infection. Each infection results in 4 new infections. Basically, the World Health Organization says each infection is going to give you a new infection of 1.4 to 3.9. So for the purposes of this conversation, I say each infection will give you at least 4 new infections. So let's look at contact tracing and see how this all goes about. So initially, there's a testing of a suspected person, or somebody tests positive. Once you get tested positive, then there is identification of persons with whom you've had exposure with. And especially, this is a difficult part of identification, because most people don't know when they move from being asymptomatic to being symptomatic. So the most important part of contact tracing is trying to identify people with whom the suspect would have been in contact with before they became symptomatic. That is a really important part in the identification process, because these people would now be themselves carriers of the virus. So once this identification is made, the next thing is notifications of persons who have been in contact, who have had exposure. So that once they're there is contact made with them, they can go into self-quarantine. And once in self-quarantine, then follow-up can be made by the public health officials for testings and then reviews of symptoms. And in the cases where there are no symptoms and the stay is symptomatic, then the testing algorithm, depending on the different countries and the resources, the supply chain, would go into effect. So let's look at the percentage transmission. This is a very, very important slide, because when we look at this slide, what you have here is you have 5% transmission, which is done asymptomatically. But it's very important to think about 5% asymptomatic transmission, because for every person in this 5% transmission, they're infecting at least they're creating 4 new infections. Then you go to a pre-symptomatic. This is at the point where people begin to think that, oh, my throat is itching, I'm feeling feverish. They're just beginning to get into the symptomatic phase. 45% transmission. So everybody in this phase is infecting another 3 to 4 persons. Then we get into the symptomatic stage. By this point, hopefully people are now in quarantine. But if again, they're not in quarantine, they're not sure what is going on with them, again, we have a percentage transmission of over 40%. But then the last one is what is of great interest. There are cases that are environmental infections or transmissions. That's 10% of all infections to the coronavirus are going to be environmental. They're not going to be because there was contact with any known suspect case. So it's important to look at this and appreciate the totality of it. It is said that 20 to 80% of COVID cases are estimated to be asymptomatic. So if you think about 20 to 80% people who are asymptomatic and transmitting the disease at a rate of 1 to 4, that's a huge transmission that is going on, and there are actually no traces to it. And this is where the whole element of surveillance becomes really key. So I say this, the more effective the program of contact tracing, the fewer the sick and the greater the level of economic freedom the society can transition into. Today, everybody wants to get back to work. Everybody wants to get back to business. But for us to be able to get back to business, we have to ensure that our contact tracing is heightened. We can do huge numbers of testing. We can do huge numbers of identification of people who have either been in contact with currently symptomatic patients or previously asymptomatic patients. So following our contact tracing, we now go on to testing. Testing for coronavirus is very sensitive testing. Preliminary, there are 2 ways of collecting the sample. There is a nasopharyngeal collection and an oropharyngeal collection. And this is a very sensitive collection. Just imagine somebody going into your nostril and trying to go up into your head with a swab. You have to be comfortable. The person has to be very aware of what they're doing. And if it were oropharyngeal, any one of us who has been to see a dentist in our lifetime will remember the R sound. And when you remember the R sound, and you can feel the swab going into the back of your neck, or the back of your throat, that's a very interesting feeling. But again, these are very sensitive collections, and the person doing the collection has to be very experienced to be able to do these collections. So the importance of doing the right collection, you have to have a sufficient amount of the viral RNA on the swab for there to be a proper test. As I said earlier on, it is very unpleasant for the suspect at the time of doing the collection. And also because it is unpleasant, it is uncomfortable, you might be in a position to sympathize with the suspect at the time of collection. And in the point of sympathizing, you might not collect enough viral RNA, and this is going to result in a negative test result. So it is very important to be able to, in spite of the discomfort to the patient, try to be able to get a proper collection and go as deep as possible. So why test? Of course, it's a disease, it's a pandemic now, and the virus is going around really fast. So primarily, we just want to stop transmission and prevent the spread. And the only way to stop transmission and prevent the spread is to do some testing and find out, get to know what actually exists, reduce case numbers, and end community outbreaks. Testing is great, but as I said earlier on, we still have a very big issue with the supply chain. And so while testing means test has to be availability of the test and the test material, what are the test characteristics? Test characteristics have to be available. There needs to be a testing strategy. What test are we going to use? What is going to be the algorithm for testing, which is going to be slightly different from country to country, depending on their supply chain. So while this is being developed from one country to the next, we have to think about some alternatives. What are those alternatives we're thinking about? Physical barriers. Every one of us has heard today about sanitizers and hand washing. You have to wash your hands this many times. I know a family that washes their hands every hour on the hour. That has to be done, depending on your location and your contact. Then there is wearing of face mask, but also we need to be mindful of the healthcare workers, so we're not using N95 mask when we're doing our everyday business. And then social distancing. Social distancing is a word which is, those two words are going to be around with us for a long time. Now, when we think about testing, I think about testing from three separate ways. There has to be tiered testing. We have to try to figure out which groups are going to be tested and when. It has to be targeted. And then there has to be prioritized testing. So we need to think about our healthcare workers. We need to think about them first and foremost. We need to think about the people in law enforcement. We need to think about people, transport officers, because these people are reaching massive numbers of people. And again, you're reminded that this is a droplet infection. So the spread is going to happen by people coughing or sneezing next to you. So we need to test people who are going to be in areas of mass populations. So let's talk about the testing methodologies. And this is where the science actually comes into play. So when you look to the left of your screen, the RT-PCR, commonly known to the scientists as the reverse transcription quantitative polymerase chain reaction. Most people just call it PCR, which is acceptable. Basically, what happens with PCR? PCR actually says it determines the active viral presence, which says you're sick and you're sick now. The collection is going to be nasopharyngeal or oropharyngeal swabs. And this is a very, very highly sensitive test. That's what it has going for it. But it requires highly trained people to be able to do the collection or the testing. And one of the big limitations with the PCR testing is it only determines current infections. Then, of course, there is the serological testing, which is something that people are beginning to hear of. Basically, serological testing is testing using blood, and it is looking for the proteins, antibodies in the body. So when you think about the antibodies in the body, specifically we're looking at the IgM and the IgG or antigens that could be tested on human blood. So serological testing will tell you if you've had previous exposure, detect human antibodies, whether the antibodies are present in your body. That's what it's going to be looking at. And we're going to look at some schematics down below to be able to appreciate the arrival of the viral RNA in the body and the antibodies that are in the body that actually tell us the different phases of where the infection is with you. Typically, if you do the antibody testing, unlike doing the PCR testing, you could collect blood from any part of the body because there is an even distribution of the antibodies, as opposed to the PCR testing. You have to go into the nostril or you have to go into the back of the throat to be able to collect the sample. The big downside on the serological testing, it says you've been infected or you've been exposed. Basically, it shows that you've had exposure. So testing. Serological assays can be used in large scale, and a lot of countries are using them in large scale. Whole population testing to assess the overall immune response to the virus and identify asymptomatic carriers. Because remember again at the beginning, we have a 5% transmission rate from a huge group of people, asymptomatic and pre-symptomatic. So with the antibody testing, we're able to identify this group of people, and that is very important in helping to be able to manage it. So let's look at the infection progression. This is a very animated slide. So day one, if you look right up just below the head, you can see the SARS-CoV-2 virus just beginning to appear in the patient. And then by the time we get to day 7, the onset of symptoms. It's very important to note what happens between day 1 and day 7, because there's an actual presence of the viral RNA in the person. There are no antibodies that are building up at this time. So the PCR test will be able to tell you definitively that you are infected. However, just about this time, you will begin to develop antibodies to the virus. So by day 14, you're pretty infected. You should be totally isolated so that you reduce transmission rates. This is almost, at this point, this is 40% of transmissions happen at about this point. But hopefully by day 14, if you've gone through a proper isolation process and you've gone through treatment, you should begin to look like the last set of schematics. The virus should be weaning off and the patient should be going towards recovery. So this is infection progression. So now we take that slide and then we superimpose it on the actual chemistry of what is going on in the body. So if you look at the curve starting out of 0, that is usually when you get the viral infection and you're still asymptomatic, coming all the way up to day 5. Just past day 5, so 3 days into being symptomatic, then you begin to develop IgM antibodies to the virus. As your IgM antibodies begin to develop, the viral RNA in the body is also beginning to peak by day 14. And as the peak begins to come down, you're at this point also developing antibody IgG. The IgG antibody remains in the system for a very long time. But this is what we want to be able to differentiate here. So we have the SARS RNA virus, we have the antibodies IgM and IgG in the body. Basically, what do you see here? You notice that by day, I would say by day 10, you already begin to have full-blown antibody detection. So if you did a serological test, a blood test, it's going to show that you've been exposed. If you also did a PCR test, which is a collection of the swab from the nostril or the back of the throat, it will also show that you have a current active virus in the body. However, when you start going towards day 21, if you look at the bottom of the graph, if you start going towards day 21, what you notice is, if you do a PCR test at this point, it is likely to be negative because the viral load in the body has also begun to reduce. And at this point, your best test will be an antibody test because it's going to be able to show that there has been exposure. But the PCR test could very easily be negative at this point. And that's why I'm very quick to say that it is very important to do a combination of tests because at the very onset, you might not be able to have any antibody detection. However, you will be able to have a PCR detection. And so, and the later phase, you might do a PCR test and you will have no detection, no reaction. However, an antibody test will give you a reaction. So a combination of tests depending on the population and their exposures is very, very important to be able to determine the infection rates in the country. So just to emphasize the IgM and the IgG again, so you see the IgG antibodies, they show up just at about day 7. This is at the same time that the viral RNA is also showing up in the body. So just at about this point, it is very possible to do a serological test that would come out with results negative. However, a confirmatory test with the PCR would certainly say you're positive. Again, you look at from day 7 going onwards, your IgG begins to form in the body, and the IgG actually lasts in the body much longer than the IgM. So if you did a serological test at this point going past day 7, you would eventually find out that yes, you had exposure, you might have been asymptomatic all throughout your disease phase. but yes, you did have exposure. So this is just a nice slide. I really wanted to throw this slide in, otherwise it wouldn't look scientific enough. But this slide basically just takes us through the IgM and the IgG. So you see how the IgG on day 14, basically the IgM, sorry, on day 14, the red Ys, for a bit lack of a simpler way of putting it, is all over the body. But then when you go on to day 21, what you're left with is the IgG, which basically goes back to reiterate the physiognomy in the body of what is happening with the antibodies. So this is exactly what the expression is to the layman. So serological results and next steps. When a serological test is done, there are always two alternatives. There's a reaction or there is no reaction. On the left side of the screen, if it was reactive, then you would go on into a PCR test, confirm that it is positive. And once it is positive, the patient goes into isolation for treatment. However, if this was contact tracing and the patient showed up non-reactive the first time on day 1 of testing, you remember when you looked at our schematics earlier on, the antibodies would not have developed earlier on in the disease phase. You allow the patient to wait another 7 days, and then you repeat testing. At the repeat of testing at day 7, what you will get is you most probably get a positive reaction, and then you move on to a PCR test, and then if it's still positive, the patient goes into treatment. If the PCR says it's negative, then you hold the patient out for another 13 to 14 days for a future test. However, on the extreme right, if your second test says antibody serological testing says the patient is negative, then the patient is negative. By this point, the antibody should have developed in the patient's body. You might want to hold the patient out for a 13-day test, and if they're still negative, you release them into the community. So basically, this is what your serological results tell you and what your next steps would be. So there remain challenges and risk in considering widespread testing. Challenges, yes. Risk, yes, because if you do antibody serological testing earlier on, you might not find the virus, and you let the person go around asymptomatic. So we still have challenges and we still have risk with widespread testing as the sole criterion for returning to work and activities. So we need to have a combination of things, alternatives, to be able to put in play to get people back to work. So what are testing limitations? Sample collection practices. Poor collection will give false negative results. That's something we need to be aware of. Test the performance reliability. As of today, the Food and Drug Administration is still issuing emergency use authorization. Most of us have heard of EUAs, and basically it says that there is still more data that is needed for us to be able to be sure about the sensitivity and specificity of the different test kits that are out there. Then, of course, there is uncertainty of the serological positive results. As I've said many times before, what does a serological positive result mean? Does it mean that you would not get infected in the future? Does it certainly say that you've been exposed? And how long is the exposure going to be good for? So we come to what everybody is very anxious about the world around, whether you're in China, in Korea, in Europe, or the States, or even back here on the African continent. People have been at home for a very long time. And just this last weekend, I was listening to the news, and there was a family that went out for a Mother's Day party. And just out of a coincidence, one of the members of the party started coughing, but made a joke about it. Oh, I don't have the virus, I just have a cough. However, when the health officials were brought in and tested, to their greatest surprise, they found out that they had just been exposed to a positive COVID patient, and there were 5 people there who had also become exposed. So the lockdown, there are a number of things that governments are taking into consideration as they look at lifting the lockdown. Do we have enough hospital beds, hospitalization rates? When the lockdown becomes lifted, can we take in enough people, and do we have hospital beds that can ensure that all of these people who become newly infected with lifting the lockdown can go into hospitals? Do we have the right number of ventilators? Is the supply chain ready for us to lift up the lockdown? Then, of course, there is the antibody rates. Antibody rates are important because we want to know community-related exposures. We want to be able to see what exposures are in the different communities. Have people been exposed? Are they still asymptomatic? And then diagnostic rates. How fast can new cases be identified? Again, this is a very big problem because we want to test as many people as possible. And as I mentioned earlier on at the beginning, we still have a supply chain issue. We don't have enough reagents to be able to test as many. Looking at today, to ensure that we can do a lifting of the lockdown, we have to ramp up testing. I'm talking about testing anywhere between 15 to 20,000 tests per week and moving on to even 50,000 tests every 2 weeks. That's the kind of volume of testing that I'm looking at for us to be able to keep control of the virus. Then infection rate. Can the rate of infection be reduced? Remember, I said earlier on in the transmission that every new infection is liable to generate 4 new infections. So we want to be able to bring the infection rate down to 1 or less than 1, because bringing down the infection rate allows us to be able to lift the lockdown. So talking about lifting the lockdown, there's some key populations that we want to think about. We want to think about people who are at risk, individuals who must remain at home, the elderly, the people who are vulnerable. They might have asthmatic problems, they might have breathing problems. We want to be able to keep them at home. People, when we get into work, social distancing has to be emphasized. We just really need to stay away from each other, put on our mask, wash our hands as often as we possibly can. And then business must get back to normal. So there's going to be, we need to restore the normal levels of staffing, but we need to do this at a very escalated rate. So just as I conclude, I just want to show you a few slides, some things that we should be very familiar with. Sanitize, sanitize, sanitize. Wash your hands. They say when you wash your hands, count up to 20. And if you wash your hands and you count up to 20, you're certainly going to wash off the virus. There are all kinds of sanitizers out there. And then please wear a mask, And oh my God, there are people who have come up with great ways of inventing nice new masks that you could actually wear and dress to suit. So you wear a nice suit and you get a mask that actually fits with your suit, or ladies with a nice mask that suits with your dress. But then again, there are these pictures of social distancing. So I want to thank you all for listening to us today and for joining us in this presentation. You could please certainly reach us by email or phone and Facebook. I think there were 1 or 2 questions that came through. Are we able to share the slides of this presentation? Yes, we are. If you drop us an email at info, we certainly would be glad to share the slides with you. I think the one most important thing that I missed here is I did not put my acknowledgement page, but I certainly want to send acknowledgements to Find. I used a number of their slides and information from them. To the McKinsey Group and Company, I did use some work from them. And of course, to WHO, CDC, Atlanta, and most importantly, the associates at the Global Healthcare Public Foundation. You could invite 1 or 2 questions from the Zoom meeting. Yes, I certainly have enough time to invite a few questions. So if you write up your questions in the chat line, they would certainly be fed over to me, and we'll try to answer them. Anybody thinking of any questions or any remarks, comments, suggestions? The issue on stigmatization, yes, that's a big question. That's a big question. A lot of people, I think I think the issue around stigmatization is actually stems from the very onset of the pandemic. I think one of the big mistakes that happened at the very onset of the pandemic was fear. There was a lot of fear that was instilled into people, and people actually saw doomsday ahead of them. And so that stigmatization on day one has actually created a huge fear in a lot of people. But how do we avoid stigmatization in the post-recovery? I think we need to get our leaders out. We need to, Boris Johnson, England. Boris has done a phenomenal job since coming out of treatment. He was out, he's been talking about the infection. The other day, there was a very nice picture of him serving tea to the news call. And that is really important. We need to see our leaders out. We need to see our leaders saying that, yes, you can return to the community. And yes, once you've gone through treatment, and as I said earlier on, just remember, one of the slides clearly shows that there are a bunch of people who are walking around and they're asymptomatic. So for those people who are asymptomatic, that actually says that they're living in our community. So the need for stigmatization should actually be closer to zero. I think we need to ramp up testing. We need to show through our serological testing that there are people who are now turning up positive, which means at some point or another, they had been exposed and they're still living economically gainful and useful people to the communities. So I invite people who have tested positive, who have either recovered from hospitalization or who have tested positive to a serological test, to go out and speak strongly and say, hey, here I am, there is nothing to stigmatize me about. Let's see, we have another question here. How affordable is the cost of testing? Most countries are doing free testing at the moment. This is a public health emergency, and most countries, almost all countries, WHO is making available test kits to country after country. So at the moment, testing should be free. For most countries that I know of, testing is actually free. So please do not go to any health center and ask for a test. Stay at home and call the health center closest to you. All ministries of health in every country around the world have a hotline for COVID. Call that hotline. Tell them what you're thinking about. Ask to be tested. And there is going to be some questions, a bunch of questions at you. And finally, there would be somebody from the health office who would come out to collect samples for testing. So please do not go to any health facility. Stay at home and make a call, and the health workers will come out to you to collect your sample for testing. What's the effect of a normal cloth mask? The essence of masking right now is, again, as I said at the beginning, this is an infection that is actually transmitted by droplets. So the opening of our mouth, I could just imagine if somebody was to swap my computer right now, I've been standing in front of it for the last half hour, how many droplets they're going to see. So that's basically what is happening. This is a droplet infection. So if you wear any kind of mask, what you're going to be doing is you're going to be protecting other people. So this is a very, very important thing. When you wear a mask, what you are saying to the rest of the people in front of you, what you're saying to the world is, I respect you. I don't want to infect you. This is not about you. Wearing a mask is mandatory because you are respecting the people in the community around you. You are saying to them, I respect you. I don't want to infect you. So I strongly encourage everybody to find some kind of a mask and put on. I'm glad the questions are coming. It means you're getting comfortable with what is going on. What are your thoughts on reinfection? I think at this point, COVID is very new with us. I think one of the things that has been said over and over again as we move towards trying to get a vaccine is we really don't know the whole story of COVID. We need to see COVID go through a whole year. We need to see COVID in 12 months down the line. We need to see COVID in 18 months down the line for us to be able to tell whether there is any climatic conditions that will create it to come back. What actually would be a reason for COVID to resurface. At this point, we just don't know, but we just need to be very careful. We just need to be protective of ourselves and the people around us. We just need to get very, very local studies done. There are studies going on in Asia. There are studies going on in Europe. There are studies going on in North and South America. And so we need to have studies going on in Africa. So we actually are able to determine exactly what is going on with the virus and where, so that when we think about reinfections, we might be able to know what vaccines do we want to have and how can we protect ourselves from it. How many months can you use each of? Oh, basically, if you are going to use a cloth mask, it is strongly recommended that you have 2 of them. So every evening when you get home, you wash one, wash it with some soap, allow it to dry, and then use the hot iron to iron it, just in case there is one very stubborn virus that stayed into the mask. Then wash it to dry, let it dry normally, nicely, and then use a hot iron to go through it, actually iron it properly. And in that time, you'll be wearing your second mask. So I strongly recommend that if you're going to use cloth masks, you have at least 1, 2, 3 of them, so that you can rotate them and have them properly washed, properly dried. It is also strongly recommended that you try to dry them to sunlight, because the ultraviolet light from the sun will help kill the virus. So yes, 2, 3 masks, cloth mask would be very recommended. I thank you so very much for joining. Please, if you do like this, I urge you very strongly to please share this with as many people as you possibly can. We're going to be loading this on our hangars hopefully by the end of today. And I look forward to seeing you next week, 3 p.m. Uganda time, and we'll have another discussion with you on some very exciting topic around COVID-19. Thank you. See you next week.